All right, hello everyone. So my name is Christopher Xenakis. Today is May 23rd, 2022, and today I'm going to be presenting my final project. I do feel a little biased because I do work as a medical assistant in a dermatology clinic, um, but I just find this disease really fascinating to learn about and also learn about the symptoms and the pathogenesis of it. We talk about it all the time at work, and that's melanoma, which is the deadliest type of skin cancer that a person can have. So, melanoma develops in the cells that produce melanin or melanocytes, which provide the pigment for uh, giving your skin its color. It occurs after like DNA mutations due to high exposure to ultraviolet radiation from the sun or even tanning beds and salons. An example of this is BRAF, which is an oncogene that is often altered in melanomas. And the most common mutation you would see in this gene leads to what's called the PV600E protein substitution. So in the United States currently, melanoma is the fifth most common cancer in men and the seventh most common in women. And there's about like 50,000 cases diagnosed annually, and usually 15% of these cases lead to death, but that's only due to like negligence, not having your annual skin checks by a dermatologist, and just not using sunscreen or just exposing yourself too long in the sun. The etiological factors for melanoma can be like family history, in which there's a 5 to 10% chance in patients, and even a 2.2-fold higher risk when someone has at least one affected relative. Having blue eyes, fair hair, a pale complexion, pretty much saying that anyone that has an easy skin reaction to sunlight or gets easily burned. Someone who freckles a lot, having excessive benign or dysplastic looking melanocytic nevi. Size in this case usually doesn't matter. It's just like really only the population number of the nevi, and if one is in an immunosuppressive state. In addition, like stated before, if someone has a lifetime of sun exposure, which can lead to formation of like pyrimidine dimers or deamination of cytosine into thymidine. And if they live at a low altitude, aka living close to the equator where there's more sun. And to diagnose melanoma, you would have a clinician or dermatologist assess the lesion with an unaided eye, or even with the use of a dermatoscope, which is a special instrument that can provide like a magnified view of the lesion. And they usually go by the ABCDE rule. So A for asymmetry, B for irregular border, C for color variations, D for diameter, usually anything greater than 6 millimeters, and E for elevated surface. And the most common syndrome that melanoma kind of falls under is the FAMMM syndrome, which stands for the familial atypical multiple mole melanoma syndrome, which is an autosomal dominant genodermatosis that is comprised of like multiple melanocytic nevi, usually more than 50. And the person also has a history of melanoma in the family, so that kind of doesn't help the case. And the CDKN2A gene is the gene that gets mutated in this situation and is even showed links to increased risks for development of pancreatic cancer and other malignancies. Clinical manifestations that are associated with melanoma are like new lesions, bumps, marks, or even moles on the skin that have been present for a short period of time that have changed in size, shape, or color, sores that don't heal, the spread of pigment from the border of the spot into the surrounding skin, redness or swelling beyond the border of the mole, itchiness or tenderness or pain even in the spot, or change in the surface of the mole like scaling, oozing, or even bleeding. And for metastatic diseases or metastatic melanomas that have spread to the other parts of the body, the patient can experience swollen or painful lymph nodes, which is very, very common even in other types of cancers. Headaches or seizures, fractures or bone pain, loss of appetite, unexplained weight loss or hepatomegaly, which is increased liver size, difficulty breathing, or even persistent cough. This implies that melanoma can spread systemically, so to more areas other than the skin. Melanoma does have the ability to develop in or near a previously existing precursor lesion or in any segment of healthy looking skin even. It can even appear on other parts of the body that are not exposed to the sun, like your palms, your soles, or even the perineum. Examples of lesions that are precursor lesions of melanoma are common acquired nevi, dysplastic nevi, congenital nevi, and cellular blue nevi. A melanoma will have two growth phases. So the first one is the radial phase, where it will grow in a radial fashion in the epidermis, and over time can then grow to the second phase, which is the vertical phase, where the cells have invaded the dermis, which is the layer beneath the epidermis, and can metastasize. It most commonly metastasizes to the skin and lungs, but can sometimes metastasize to the small bowel. We can have four types of melanoma. One is superficial spreading melanoma that comprises around 70% of melanomas. It's usually flat, can become irregular though, and elevated later on. And it'll average like around 2 centimeters in diameter. The second type is nodular melanoma, which is 15 to 30% of melanomas, and they're usually blue and bluish blackish, but can lack pigment in some occurrences as well. The third is Lentigo malignant melanoma. Lentigo maligna melanoma, which is around 4 to 10% of melanomas and are usually larger than 4 centimeters. They're flat, they're usually tan with around like notched borders. And the last is acrolentiginous melanoma, which comprises 2 to 8% of melanomas in light-skinned people, and 35 to 60% in dark-skinned people. And these can appear on the palms, soles as like flat tan or brown stains with like irregular borders. And the most important diagnostic test one would use to diagnose someone with melanoma is a skin biopsy, whether that be a shave biopsy where they kind of like shave off the top layer of the skin. But this is usually done when melanoma is not as suspected, since the sample may not be thick enough to measure how deep the melanoma has invaded the skin, or they can use a punch biopsy, or they can perform a punch biopsy, depending on how deep they want to remove it for the pathologist to take a look. It'll then be sent off to a dermatopathologist lab. They'll then examine certain features such as the tumor thickness and the mitotic rate, which can help indicate the stage of melanoma if it is melanoma. And a differential diagnosis that can accompany melanoma is an epithelioid or Spitz tumor, which is an uncommon benign melanocytic nevus that's usually acquired, has the same histological features as melanoma. Usually it's characterized as like a symmetric, kind of well circumscribed, can be smooth surfaced or wart-like surfaced, very firm, kind of dome-shaped nodule that's less than 1 centimeter. It can appear by itself or it can appear in clusters as well. They're also very uniform in color, and like I said, they are similar to melanoma, but they were studied by researchers to not have the same malignant behavior, so that's kind of how you can differentiate that from melanoma. And there can be complications if treatment or diagnosis, even of the melanoma, is delayed. That includes like secondary infection, since the melanoma has already begun to invade sensitive areas of this normal skin barrier. There can be scarring, there can be lymphedema, there can be local recurrence, especially if the melanoma is more advanced than it was at the time of diagnosis. There could be metastases, and even depression and anxiety the person or patient can feel due to the possible aesthetic look of the melanoma lesion. And that's about it. Thank you guys for listening. Hopefully everyone's doing well.